Hello and welcome to Bite-Size MRCP, a manageable way to digest the things that you need to know for your MRCP examinations. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the material covered are by no means an exhaustive list of what can come up in your exam, or indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on diffuse cutaneous systemic sclerosis under the rheumatology section. So, you would have remembered from the previous lecture that cutaneous systemic sclerosis are divided into limited and diffuse subtypes, and today we're going to be talking about the diffuse cutaneous systemic sclerosis. Please refer to our previous video, which will go in depth about the limited cutaneous systemic sclerosis and everything that you need to know for your MRCP for that topic. So first and foremost, what is diffuse cutaneous systemic sclerosis? It's a connective tissue disease with thickening and fibrosis of the skin, which is formerly known as scleroderma, and more importantly, it can have wider organ involvement. In diffuse form, it frequently involves face, trunk, proximal, and distal limbs. As for its epidemiology, it is quite a rare disease. The incidence is about 4 to 12 million per year worldwide. It affects all racial groups and it affects females more than men, with a ratio of about 4 to 1. In terms of the clinical features, you would be suspecting this syndrome in somebody who presents to you with skin thickening, which frequently involves neck, face, distal or proximal to elbows, knees and trunk. It can sometimes manifest as a renal crisis, which is certainly more common than the limited form, and in that you will be presented, especially in MCQ questions, in a patient who's presenting with malignant hypertension and a rapidly worsening renal failure. And like many other connective tissue diseases, pulmonary hypertension is one of the biggest killers in the syndromes. However, it is important to note that the frequency of it is less than limited cutaneous systemic sclerosis. And in some cases, it could lead to fibrotic interstitial lung disease. More on the clinical features. In terms of, if you divide it in terms of systems that it frequently involves, as for the musculoskeletal symptoms, it can present as arthralgia. About 30% of patients present with an erosive arthritis. It could present as a first presentation of myositis, flexor tendon deformities of fingers due to skin fibrosis, and sometimes it could present as a carpal tunnel syndrome. In your station 5 in PACES, carpal tunnel syndrome or bilateral carpal tunnel syndrome is one of the frequently encountered ones, so it would be important to mention this and think about this as part of your differential diagnosis. As for the gastrointestinal symptoms, it could present as a result of impaired motility at any point of the GI tract. So you could get reflux, dysphagia, peptic strictures, gastric dilatation, and sometimes it could lead to bacterial overgrowth and malabsorption syndromes, which could potentially result in pseudo-obstructions. And that is quite MRCP classic, especially when you're talking about your MCQ questions and your part 1 in your part 1 and part 2 exams. So, what type of investigations would you want to do in someone who is presenting with signs and symptoms suspicious of diffuse scleroderma? So you would certainly want to be checking your inflammatory markers such as ESR and CRP, which would be elevated. And overall, in terms of the antibody panels, you would want to have a full antibody panels, and that is, you would have an anti-nuclear antibody, which is positive in about 90% of cases, and also rheumatoid factor, which is positive in about 30% of cases. However, the most specific antibody, which is very important for your multiple choice question, is anti-SCL7T, which is positive in only 20 to 40% of cases. However, it is the most specific antibody in this condition. As for the management of it, the management really begins with supportive care, and that is the use of painkillers and anti-inflammatories for your arthralgia, your proton pump inhibitor or famotidine for gastric symptoms if relevant, and you would consider intermittent antibiotic if you're suspecting a case of bacterial overgrowth in the bowel. As for the Raynaud's phenomenon, that is one of the symptoms that frequently go hand in hand with the diffuse form of scleroderma. It's really the basics that you would be following and advising the patient for any case of Raynaud's. Obviously, this would be a secondary cause of Raynaud's, and if you want a refresher on the Raynaud's phenomenon and the difference between primary and secondary and the detailed management of them, please go and visit our appropriate video on that. But just as a quick summary, you would be encouraging the patient to wear gloves. You could consider vasodilators, medications such as nifedipine, sildenafil, especially if you're worried about the causes of digital ulceration or pulmonary artery hypertension. And finally, in severe cases, you could consider iloprost infusion or prostacyclin. In terms of the disease management of the actual phenomenon itself, you would start the patient on disease-modifying drugs or DMARDs. It's difficult to say which one exactly due to the heterogeneity of the disease, and it really is something that you would want your specialist rheumatologist to be involved in the care. And in general, the drugs that you could possibly consider are methotrexate, mycophenolate mofetil, rituximab, cyclophosphamide, especially for severe diseases and the cases who have got lung involvement, such as interstitial lung disease secondary to systemic sclerosis. So let's do some questions now. A 30-year-old female presented a rheumatologist with a history of skin tightening in her fingers, face, neck, and legs, from the thighs down to the ankle. She's markedly short of breath and has a blood pressure of 160/114. Given the likely diagnosis, which antibody is the most specific to her condition? So you've got a young female who presents with what the case is describing as a multi-organ involvement affecting different parts of her body, and you're getting that it also has an involvement in her respiratory system. The options you've got is A, anti-SCL70, B, ANA, C, rheumatoid factor, D, anticentromere, and E, anti-Jo1. And if you recall correctly from when I was talking about this condition, which is diffuse cutaneous systemic sclerosis, you will realize that the most specific antibody is indeed anti-SCL70. Question 2, which of the following may be used as a first-line treatment in scleroderma renal crisis? A, amlodipine, B, prednisolone, C, methotrexate, D, captopril, E, piperacillin tazobactam. So this question is trying to get you to think about one of the most important, both clinically and academically encountered questions, and that is the management of scleroderma renal crisis. A lot of you might have thought that if you have an autoimmune condition and if they present with a flare-up of that condition, you might consider prednisolone, as you have seen in many other conditions. However, this is not the case in the case of scleroderma, and this is something that you either know it or you don't know it, but fortunately, as you're covering the question now, hopefully when it comes to the exam on test day, you would be able to answer it confidently. And the correct answer in here would be an ACE inhibitor such as captopril. Thank you for listening to this episode of Biosides MRCP. If you like the sound of what you hear today, give us a thumbs up and hit the like and subscribe button below to make sure that you don't miss on our future episodes. Let us know in the comment which topics you would like us to hear in the future. See you in the next episode.